Okay, so next we're going to go over imaging of PNETs and just kind of try to cover some of the basics here. So this is a nice table that summarizes the different things that you can use for imaging and their sensitivities. So, the two kind of basic ones that we're all aware of, probably the two most common that are used, particularly for screening, is CT and MRI. And typically we just use CT here. So again, these are good for initial evaluation. Their sensitivities are both pretty similar in the 80s. The both are not very good at detecting very small lesions, particularly things like the small insulinomas, gastrinomas, and that's why intraoperative ultrasound and things like that are so important for those. And we'll go over kind of what these look like on CT in a second. EUS has reportedly high sensitivity, but it's very user dependent, of course, like all ultrasound. But EUS can be used. It's just difficult for an EUS to survey the whole pancreas. So it's better if you have a good idea of what part of the pancreas you're looking at. And then along with EUS, I think also goes intraoperative ultrasound, which is reportedly very sensitive for finding smaller lesions and should be an important part of the surgical management of particularly hereditary PNETs, as we'll talk about. Octria scan, so this is one that probably most of us use in residency, but is now, as it says here, now obsolete. It's at least becoming obsolete. And so we'll talk a little bit about the difference between octreotide and the newer version of somatostatin analog imaging, which is called a dotatate or dotatalk. Dotatate seems to be the one that's kind of dominating. So we'll go into a little detail on those. And then PET scans. PET scans are not going to be very useful for PNETs in general because they're going to be low or excuse me, they're going to be well or moderately differentiated. So these low-grade tumors do not show up well on PET. So the only tumors that would show up on PET are high-grade or poorly differentiated, which again are classified. The poorly differentiated are classified differently. So general PET is not very useful. FDG PET is not very useful for PNETs, although this new dotatate imaging is a form of PET scan. So just quickly, this is a PNET on CT scan. So arterial, it's going to be hyperenhancing. It's going to wash out in portal venous phase. And then importantly, with a true pancreas protocol scan, you're going to get early and late arterial phase. Sorry. And so this is PNET lesions in the liver. And what you see here is they're going to hyperenhance on early arterial, and then especially the edges are going to stay hyperenhancing on late arterial phase, which helps differentiate from some other lesions, particularly in the liver. And then again, they wash out in the portal venous scan. And this kind of sharp demarcation of hyperenhancing on the edges is characteristic of PNETs and also is considered a good characteristic for a well-differentiated tumor. So the less infiltrative and the sharper the edges are, the better, the more likely they're going to be well-differentiated and low-grade. All right, so somatostatin receptor scintigraphy. So again, we all know about Octria scan. Octria scan uses a somatostatin analog that's labeled with indium-111 and requires SPECT imaging. So typically they give the drug and the images are obtained 4 and 24 hours after, sometimes again at 48 hours, but typically just those first two, and then again SPECT imaging. One key point here is that it only that somatostatin analog that it's used only binds to receptor type 2 and 5, and insulinomas typically express type 3. So these Octria scans are particularly bad for insulinoma. That's kind of a piece of trivia, but might come up. This is what you get: SPECT scan with the tumor lighting up. Same thing there. So now this is the dotatate scan, which is kind of the newer, latest, greatest thing. So this uses gallium, and then this dotatate is a chelator. So gallium is a radioisotope, dotatate is the chelator, and then the peptide is another somatostatin analog. So this one thing is that this somatostatin analog does bind a little bit more ubiquitously to somatostatin receptors. So it binds to 3 of the 5 types and seems to cover most of these PNETs. So that's one thing that makes it better. And then the other big thing is that it's combined with PET instead of SPECT imaging. So the images are sharper and it's a little easier to demarcate the tumor. So PET imaging is just in general better than SPECT. So there's not a ton of great literature, but a couple quick studies on this. So this one just compared PET, basically dotatate PET versus just a contrast enhanced CT scan, so normal CT scan. And they looked at 45 patients and used them as their own controls. So 25 of them were lymph node positive by pathology, and the dotatate scan picked up 23 of those 25, whereas CT only picked up 16. And then as far as bone mets, that was another spot where it did very well. So the dotatate picked up 17 out of 17, sorry. Whereas the CT only picked up 8 out of 17. So this small study showed that dotatate scan more sensitive than just regular contrast enhanced CT scan. And then this is a review of dotatate compared to Octria scan, as well as just regular CT scan. And they reviewed a bunch of papers. Only 3 of them were dotatate versus Octria scan, but the dotatate did show better sensitivity. And then 9 studies, dotatate versus CT or MRI, and dotatate showed better sensitivity and specificity. So the literature is kind of early on this, but it does appear that the dotatate scan is better than CT or MRI, and probably is how we'll be imaging these in the future. One thing is that not all insurances currently cover these, and so that's one reason not all patients get these scans. So I think they're really pushed for when patients have liver mets and you're planning surgery and you want to make sure that you're not missing other mets when you go to the operating room. So those, I think they're basically used right now just when the finer imaging is really felt to make a difference. But I think in the future it'll probably be more widely used. So, and this is just one picture from this article showing the difference between SPECT imaging and PET imaging. So you can see just that it's a lot sharper, and you can see these smaller tumors in the liver that are almost impossible to see on the SPECT imaging. So that's one reason that dotatate is favored. And then this is just a nice picture from one of the patients from MD Anderson of their dotatate scan. So you see the primary tumor lighting up here, and then you can see the background of the liver versus the tumor lighting up. So it does demarcate these tumors very well. So I just want to say a brief word about hereditary PNETs, because they are a little bit different than the sporadic. So the biggest thing is that sporadics are going to be solitary, the inherited are going to be multiple. So that does change your management somewhat. MEN1, most common cause of hereditary PNETs. We all know about the MEN1 gene, autosomal dominant. You're going to have parathyroid hyperplasia in all patients, pituitary tumors in less than 50. And then PNETs are going to be in 80% of these patients, so they're very common. However, they're not always symptomatic. So the most common is still going to be non-functioning PNET. So a lot of this 80% may not present early on with a tumor, but you just have to keep in mind that the majority of these MEN1 patients will develop PNETs at some point in their life. The biggest thing is that more than half are going to be multifocal, so you really have to keep that in mind with surgical management, that you may see one lesion but miss the other, so you have to be very thorough in searching for multifocal lesions. 50% are going to be metastatic at diagnosis, and then this I thought was interesting, 50% of these patients will actually die from their PNET despite having other tumors. So it is a significant source of mortality for these patients. And then other syndromes, von Hippel-Lindau, you're going to have pancreatic cyst as well as PNETs, typically non-functioning. And then the other things we typically associate with it, neurofibromatosis 1 is also associated with PNETs, and tuberous sclerosis as well.